An overview of the agenda for our meeting. We will have 3 presentations. First will be Kathy Hummel, Dr. Cheryl Clark, and Dr. Suzanne Judd. Then that we will have an opportunity for questions and answers at that point in time, and we'll have some closing remarks. Now, I would like to introduce our presenters for this meeting. First, Kathy Hummel has a master's degree of science in nursing. She is a registered nurse practitioner and certified clinical research professional. Kathy has been in research for 16 years. She is currently the Arkansas Hub clinical site manager for the Recover PEDS cohort and manages 14 other research sites throughout the nation. Next, Dr. Cheryl Clark is a hospitalist and health equity researcher at Brigham and Women's Hospital and a co-investigator for the Recover program in Boston. Dr. Clark's research focuses on social determinants of health, and she co-chaired the All of Us research program Social Determinants of Health Task Force to develop the SDOH module for use in precision medicine research. And finally, we have Dr. Suzanne Judd. She is the director of the Lister Hill Center for Health Policy and a professor in the School of Public Health at the University of Alabama at Brigham. Dr. Judd is a multiple PI in both the regards and rural cohort studies, which are large NIH-funded epidemiological cohort studies seeking to understand disparities in chronic health disease in the United States. We welcome our presenters. We will begin with Kathy Hummel, who will be discussing retention strategies utilized by the Arkansas Hub for Recover PEDS. Ms. Hummel, you may begin.
Thank you, Marta. We can go to the first slide. Today, we'll be discussing who we are, retention strategies utilized by the Arkansas Hub sites, which include decreasing participant barriers or those participant burdens, community building strategies, and improving follow-up rates for study visits, which lead to increased data collection. Next slide, please. So who are we? We are 14 research sites strong. We're spread across the nation. We're colored here in yellow on this map. As you can see, our reach is as far as Hawaii, Louisiana, Puerto Rico, all the way over to the East Coast with South Carolina, all the way up to north to Vermont and New Hampshire. Next slide. As researchers, we know that engaging and retaining our participants is critical to the integrity of our research outcomes. We recognize that we do have specific challenges with Recover PEDS, mainly because it's a longitudinal 4-year study. But despite these challenges, we do have multiple retention strategies that we can use that will help maintain our participants in Recover and keep them engaged. We're only 13 months post-enrollment, so we're just now starting to see which of these retention strategies work and which ones don't work so well. So for the purposes of this presentation, I've broken down our strategies into 3 categories: decreasing that participant barrier or burden, community building strategies, and improving follow-up rates, which lead to increased data collection. Next slide, please. So decreasing participant barriers or participant burden. This is the largest category of the 3 with probably the highest impact on retention in Recover PEDS. The first here is just offering different ways to conduct study visits. In addition to the traditional face-to-face study visit, Recover PEDS offers remote visits for the first phase of their study. Visits can be done via teleconferencing in addition to home visits. Home visits are not uncommon at all for our Puerto Rico site. Next slide. Offering different ways to collect surveys. Recover PEDS is weighted heavily with participant surveys, so offering different ways to collect these surveys has been a game changer for us. In addition to completing the surveys face-to-face, we're able to have participants complete their surveys via the web or mobile device, via the telephone, and even paper for those that don't have reliable internet connections. Next slide. Another way to decrease participant burden is to offer generous study windows. Our study windows are plus or minus 3 months, starting with the month 6 visit. So for an example, if a participant is supposed to come in, say July 1st, that participant could come in as early as April or as late as October and still be considered in window. They actually have 6 months to complete a study visit. So we think that these generous study windows provide much more flexibility for our participants. Next slide. Excuse me. We have an amazing communications team that develop and provide participant materials for Recover. This is just an example of a participant brochure written in both English and Spanish. Next slide. Another way that we can decrease participant barriers is to have flexibility among our study team members. So offering non-traditional working hours has worked well for some sites. Some sites may see participants after 5 p.m. for parents who have to work or who simply just don't want to take their kiddos out of school. Some sites may even offer weekend hours, or they may work during spring breaks or holiday breaks. The Recover Peds study does go up to 25 years old. So for those 18 to 25-year-old college students coming home during these breaks, this is probably the best time for them to complete a study visit. And also having the ability to schedule 2 participants at the same time is important. For example, a set of siblings who are enrolled in Recover, you really don't want mom to have to bring Susie in one day and then Johnny in on another day. You want to be able to see those participants together at the same time in one appointment. Or even friends who have enrolled together, they may want to carpool together and have their study visits at the same time to help save money. Is another example. Next slide. We think it's so important to build positive, caring relationships with our participants. We need to build rapport with them. We need them to trust us. And we can do that by utilizing study team members that have excellent interpersonal skills and study team members who are very knowledgeable regarding the protocol and procedures. Our staff need to be able to answer the family's questions. They need to be caring. They need to be able to address any concerns that the family members may have. And when it's feasible, we think that using consistent study team members will also help families become more comfortable. They're seeing that same person every time they come in, so they get that familiarity. I often think of our Pennington site when I think about building these strong relationships. Next slide, please. Another way to decrease participant burden is to provide some sort of compensation to help cover the cost of participating in the study. If you think about it, participants do have to cover the cost of their transportation, whether that's driving their own car, they need gas money, bus, train, or taxi fare, or even a cost of a flight. They may have to pay for parking during the day, and most of the times they will need a meal during the day. Also, caregivers may have to take off work to get to a study visit. So in our hub, we do provide compensation for study visits. And that comes in many forms. It could be a check, gift cards, CLIN cards. And recently, the Recover Peds CSC team has developed a travel policy that also helps assist families who live greater than 150 miles away from the site. That includes mileage and hotel. So that's been very helpful since we've implemented that travel policy. Next slide. If we can make the study visit pleasant and comfortable for the family, this is another way that we can help decrease participant burden. Offering childcare services or a fun playroom for the other siblings to play in. And when I say childcare, I'm basically referring to having another study team member available to help to distract the other child or children while mom and dad may be trying to complete surveys and complete a study visit. If the families are coming in right after school, it's helpful to offer refreshments like snacks or drinks. Then mom and dad don't have to worry about packing snacks that morning or stopping along the way to pick something up. In Recover Peds, we do a lot of neurocognitive testing. So we really need our kiddos to be focused during their assessments. So if we can make sure that they're not hungry, this helps ensure that they're less cranky and they're more able to focus on the tasks at hand. Even maybe offering lunch at the study visit is during lunchtime hours. Next slide. In addition to making the study visit pleasant and comfortable, we also want to make it fun for the child so that they want to come back and they look forward to their next visit and they're not fighting mom and dad about coming back. Our Avera, South Dakota site has a Scientist for a Day program. You can see in this little picture, the younger kids can dress up like a scientist if they want to. They have these little white lab coats, these colored protective eyewear, and these little ID badges. It's adorable. We also have sticker sheets. We have a zoo and a farm sticker sheet. Again, this is geared more for the younger children, but each time the child completes a study procedure, they receive an animal sticker and they can put that sticker in their zoo or in their farm. So by the end of the study visit, if they've completed all their assessments, they should have a whole farm full of animals or a whole zoo full of animals. Next slide, please. Now we'll talk a little bit about community building strategies we've used in Recover Peds. And just while we're on this slide, just want to point out, if you can note the branding, our communications team has created this recognizable study brand for us via logos and color schemes. We use a lot of these different shades of blue and gold in our branding. Next slide. We have a monthly Recover participant newsletter that's available in English and Spanish, where we can share our study results with the families, along with any news or events in the Recover world. Next slide. We have thank you cards, birthday cards, holiday cards that we can send our participants. We think it's very important to let our families know how important they are to us and to this study. We can help maintain those positive relationships that we've built by sending out these cards that recognize them. Just let them know we're thinking about them. Let them know that we care about them. Next slide. We have Recover swag. We have little gifts or freebies to help create that sense of community. As of right now, we have bookmarks, we have magnets, and we have bracelets with the I Am a Research Superhero theme. This is just a small way we can say to these children that you are our champions. It's just a small way for us to say thank you. One of our study coordinators from Oklahoma, Valerie, actually worked on this design with the communications team and made all these items come to life for us. And next slide, please. We have Recovered study team T-shirts. Our hub designed these T-shirts and we sent them out to all 14 of our research sites. I'm sporting one today. Again, you can see the same logo, that color scheme. Our study team members can wear these T-shirts during Recover study visits to help represent the study, kind of show that camaraderie. And we also know that these T-shirts also represent us when we're wearing them out in the community. Someone may stop and say, hey, what's Recover? What's that all about? Next slide. We've had a lot of media coverage through news segments, newspaper articles, and ad campaigns. People in the community see these things and then they know that they're part of something really big and really special. This is Avera, South Dakota. They recently had a story air on Dakota News Now about one of their Recover participants and the work that the Recover team is doing there. Their study coordinator, Maggie McCoy, had a great sit-down interview with a reporter, and that story turned out really, really, really amazing. Next slide. This is our Hawaii investigator, Dr. Jessica Kosett. Dr. Kosett's been on several news segments and in several local newspapers. She and her study coordinator, Joanne, have put a lot of time and effort to get Recover out there in their community and show the people how newsworthy this Recover initiative really is. Next slide. This is Dr. Racy from our New Mexico site. They recently launched an ad campaign at their site using websites and social posts. Kudos to that study team there. Eve, Noah, Becky, for all the extra time and effort that went into a project as big as this one. Next slide, please. And last, we have a National Recover website, www.recovercovid.org, in both English and Spanish, that participants can go to learn more about long COVID. They can learn about the Recover initiative. They can inquire about the study, and they can just keep up to date on any news and events in the Recover world. Next slide. And lastly, just strategies to improve follow-up, which leads to increased data collection. Next slide. People are very busy these days, and they often need reminder phone calls, emails, or texts about their upcoming study visits, and even to remind them to complete their surveys. Remember, we said Recover Peds is weighted heavy in surveys. Sometimes multiple attempts are needed to contact these participants, especially at the very beginning of this study. We do have to be careful here because we don't want participants to view us as badgering them, thereby damaging that positive relationship that we work so hard to build. I've always thought it'd be interesting to investigate family perspectives on follow-up, like how much is too much before they feel like we're bothering them or badgering them. I mentioned earlier, Puerto Rico study team members do home visits if that's what it takes to get the data. It's important that we maintain contact with our participants. With a 4-year study like this, many of our participants may move within that time frame, so we need to make sure we get updated current contact information at each face-to-face contact that we have with them. I'm not talking about burdening them with a bunch of paperwork at every visit, but simply ask them, is this still your same address? Is this still your same phone number? And then simply just check a box that says all their contact information is still correct and up to date. Maybe ask for their preferred mode of contact, phone call, text, email, snail mail, whatever they prefer, and perhaps the best time of the day to contact that participant. Next slide. So in summary, our hub has been employing a variety of these retention strategies. Each one of our sites is so unique. Our sites, they know their communities, they know their participants, and they know how to choose the best resources for them. As I mentioned earlier, we're only 13 months post-enrollment, so we're still learning what works well and what doesn't work so well. But if I had to say at this time, the strategies aim to reduce that participant burden, that being flexible in how we collect data, having those long study windows, being flexible with scheduling, offering compensation to help the participants. These might be the most effective strategies thus far. And lastly, I attribute our retention success largely to a very, very dedicated team of researchers, study coordinators, and investigators, and having the dedicated support of our communications team and our CSC. Next slide. And that is all I have for you today. Thank you so much for your time and attention.
Thank you, Ms. Kathy Hummel, so much. And as a reminder, you can continue to ask questions in the chat, and a little bit later we'll have Q&A. Now we turn to Dr. Cheryl Clark to discuss retention and observational studies guidance from the literature. Dr. Clark, you may begin.
Thank you so much. And it's such an honor and a pleasure to have heard Kathy's presentation. One, because it means that I don't have to say very much because everything is really there. We'll go to the next slide. I will really focus on underscoring a lot of the themes that Kathy has already illustrated in practice that are related to the literature. Just some themes and some evidence for the strategies that Kathy raised, as well as some emerging strategies that we need to think about. A couple of practical examples for these emerging strategies, and then some recommendations and references. We'll go to the next slide. There are 2 studies in particular that you heard reflected in the prior talk that really help us to think about how retention, what some of the background and evidence is around retention. One study really is about looking at global evidence across the country in cohort studies. They looked at 141 articles over 143 cohorts across the globe, including places in the United States, for example, Midas, China, Japan, lots of cohort studies with sizes between 30 to 61,000 people. And they tried to quantify it. So they did a meta-analysis, and I'll walk you through that in a moment. And the second study by Abshire and all about 5 years ago did a more qualitative look at the top studies, about 19 with high retention rates above 80%, and did interviews with study staff to understand their perspectives on best practices. And the summary, if you take home nothing else, is really this, that there's some controversy about how many strategies are needed, but that a lot of this work does need to be tailored to site, and we're learning that. But that the top factors, at least when you quantify it, does tend to be this sort of barrier reduction, sort of building in flexibility, reducing barriers to participants. And where there are gaps in the literature are related to equity, making sure that we are thoughtful about the kinds of retention strategies that matter to diverse populations. So let's go to the next slide and look at some of the data. The qualitative study that looked at cohort studies in the US found 618 sort of discrete things that we could be doing, or at least they reference work from NHLBI, and I'll provide that toolkit to you at the end. And when they did interviews and sort of asked investigators and study staff what tended to matter the most, they broke it into about 12 strategies, which you can see on the slide. But studies with high retention rates tended to use strategies around study reminders, the visit, emphasizing the benefits of the study, making sure there was flexibility around scheduling. And there were also parts of the teamwork that you heard reflected in Kathy's presentation, that the teams themselves are well organized, they're well functioning. They try to reach out and make relationships with participants, and they're persistent and really meet their participants where they are. That teams do tailor their strategies to the participants, and they often innovate as they go. So those were some of the key findings in the qualitative work. On the next slide, there was an attempt to use a meta-analysis to quantify this from 95 discrete strategies. And there were 4 buckets that were likely to improve retention rates. Community building strategies, like having swag and branding, making sure that we communicate well with our participants through newsletters, social media, feedback reports. The barrier reduction strategies, so making sure that there's plenty of assistance, childcare services for those who need it, making sure that we engage participants as we think through how to collect data, and offering people alternative data collection strategies. Incentive strategies, including cash voucher incentives for different levels of assessment or completion of study requirements. And then finally, tracking and contact strategies. So being able to follow up to participants with phone calls or texts as they would like it at their frequency, and also collecting the details of alternate contacts so that we can find participants. Of these strategies, quantitatively, it looks like there are 2 that do have evidence. One is barrier reduction. One example is providing flexibility for people to complete study requirements on the phone and face-to-face, depending on whether they need help. And being flexible tended to increase study retention to 86% compared to 76% for those who weren't studies that were not using that strategy. And the second strategy that tended to be impactful are the tracing strategies. So those studies that were able to offer participants a locator document at baseline with alternative contact sources were more likely to stay in touch with and then retain their participants than those that didn't use a locator document. Let's go to the next slide. Where there is a gap in the literature is this idea of equity and retention. And I wanted to show you this, some of the issues that we ought to be thinking about from a consensus statement from the American Thoracic Society that really shows us as we think about what it means to address equity in long COVID. We know that for COVID, diverse populations that are African-American, Black, that are Hispanic, Latino, tended to be disproportionately impacted in COVID. And we're also noticing and trying to understand the equity issues in long COVID. And to do that, we will need to understand systemic inequities and systemic racism, how our health systems interact differentially with populations. And all of these things are things we have to grapple with as we try to recruit a diverse cohort and also retain a diverse cohort and recover. So if you go to the next slide, the ATS did put out a consensus statement based on expert opinion that suggested many of similar strategies are necessary as we think about retaining diverse populations. So making sure that we're very thoughtful about collecting contact information, those tracing strategies, making sure that we're very thoughtful about reducing barriers and participant burden, building community and identity with the study, the birthday cards and those sorts of gifts, as well as providing people with a direct connection to the study team and building those relationships. We'll go to the next slide. But what I wanted to leave you with is an emerging strategy. We are seeing this in the All of Us research program, for which I'm also an investigator, that returning value and making sure that we think well about what our participants are getting out of the study is going to be very important. Particularly important to populations who have experienced disenfranchisement and inequities, and who can't always anticipate that the results of research studies are going to reach them or reach people like them, because they may not have access to care. They may not be treated respectfully in these environments. And so as we are trying to retain people and be relevant in the lives of our participants, it's important that we use retention strategies that value those participants and their communities, including investing in community infrastructure, committing to returning value during the study, and also using our research resources to meet needs on the ground. And I'll give you specific examples of that on the next slide. One example from our work in New England relates to this idea of both returning value as well as using research infrastructure to benefit patients and to address needs on the ground. It may be really hard to remember this, but back in March of 2020, when COVID first became a part of our lives, we had very little information. There was a lot of disinformation, and many of our participants did not actually know what COVID was, what was reliable, what are the kinds of treatments. And people were also experiencing social determinants of health at the time, and still are, loss of work as things started to shut down. We in New England, the New England hub of all of us, also needed to, which is, I'm sorry, I should have said the NIH Precision Medicine Study, needed to shut down our operations. But instead of having our research assistants do filing or other sorts of tasks, we asked our participants to phone all 20,559 of our participants at that time, only for the purpose of understanding whether they were okay. We called them check-in calls. You'll see just some small icons on the side, but we were able to provide folks with references and resources locally, both on mental health, which was an emerging issue in our community, as well as on social determinants of health, where to get assistance, even trying to understand where you could get food if you were food insecure. And our engagement and retention, this wound up being a retention strategy for us. We wound up doing it in 2 phases, where we initially just contacted people about their well-being, but then we also followed up and were able to collect contact information and other things in May of that year. And there we did additional retention sorts of activities, like asking people to complete surveys. And you can read about this in our article, Care and Precision Medicine in the Time of COVID-19. And it describes specifically how groups who are diverse along the lines of race and ethnicity and income and education really did appreciate those kinds of check-ins. So this is an example of how we can use research infrastructure to provide value on the ground to communities, and also equity, and it has implications for retention. On the second slide, also wanted to show you work that we're doing in the Boston BCRC, our Boston Recover Consortium, where we are working to invest in communities. This is an example of our newsletter, which is going out, roughly quarterly, but part of what we commit to when we ask our communities to help us recruit, for example, is to make sure that we share resources. And so our Let's Recover newsletter has shared resources on where people can go to get into care for long COVID, what some of the symptoms are of long COVID. And in addition to our newsletter, which is really a sort of an electronic tool, we have also launched a community forum where we have presented data on equity and long COVID, where in future forum settings, we will conduct education on what long COVID is for diverse populations in our communities. And we will also have a session on coping and support. And we've provided information on how people can go to their local institutions where they do have access to care to get resources around coping. we are now evaluating the opportunity to use this as a retention strategy by sending materials directly to our participants, but that's in progress. So I think I have one last slide, or maybe two slides. Oh, a couple of slides. So practical tips. Very grateful to the PI of our study. So both Bruce Levy and Ingrid Bassett and other MPIs, as well as our study staff, Danielle Zions, Diane Kanjalal, and Tang Nandi Ong, who provided these strategies that we wanted to share with you on how we use some of the evidence in practice. And the first couple are really around those sort of four buckets. So the incentives, reducing barriers and improving value. So first, incentives, just the compensation is so key. It's a way that we show respect for our participants' time and effort. Strategies that have been used to reduce barriers at Mass General include taxi services. One of the participants, for example, actually broke both of her feet and wouldn't have been able to come in at all if we hadn't been able to offer a taxi voucher for her. Having community-based visits, so opening up a satellite site so that participants can come in and be able to go to a site that's closer to where they live physically has been very important. And then we've mentioned multiple times flexibility is important so that people can reschedule, that they can have big windows for doing that. A few participants, it seems, were able to be retained because they were able to offer them survey-only visits, for example, and then the opportunity to return to do the other parts of the study as they are able. One key piece of improving value is also returning results. And particularly at our sites, participants have expressed the desire to really receive their results and have even expressed some reluctance to do study procedures if they weren't able to receive those results. So that was important. We'll go to the next slide. And then finally, relationships, making sure that we build those connections with our participants and that we care about them. We use the strategy at Mass General Hospital that a primary research coordinator tends to be linked to a study participant if at all possible, and is responsible for most correspondence so that the person sees somebody that they know and can connect to. And that we also maintain a tracker and a log that has unique information about our participants. For example, their kids and what specific health status issues that they might be dealing with, that they like bluegrass music, so other things, so that we really care about our participants and can help to make people feel comfortable in future visits. Of course, professionalism, being kind and personable to our participants. So many of the communities that have been disproportionately impacted by COVID have also been disproportionately impacted by discrimination and racism and other kinds of forms of disrespect in their interactions. And so making sure that we reduce those barriers through our professionalism is something that needs to be stated explicitly. Not being afraid to do that extra step of calling participants or jumping on a call if there's some problems that an individual needs to troubleshoot, and also just showing up for people. One of the examples I think is really kind, that some of the research coordinators went to a participant's art show because the participant asked them to go, and they share music recommendations. And so it's a personable style of interacting with participants. And then, of course, asking participants for feedback on their study experience so that we can incorporate that information in the future. Go to the next slide. That toolkit I mentioned is from an NIHLBI funded study, improving long-term outcomes research for acute respiratory failure. And so we'll send you this link so that you can have access to those 618 strategies. Should we try them? And then you can look at the evidence in more detail through these references. Thank you so much.
Thank you, Dr. Clark, very much for your presentation. And now we'll turn to our final presenter, Dr. Suzanne Judd. Dr. Judd will present participant retention, the case for positive experience through customer service. Dr. Judd, you may begin.
Thank you, Marta. So I'm going to talk to you guys a little bit about a couple of cohorts that I've been with for the past 15 years. One of them's a little bit newer. On the next slide, you'll see the new cohort that we started We were lucky enough to receive funding in 2019 for a rural Southern cohort, but then the pandemic hit. So we were challenged with how you recruit right in the middle of a pandemic. And I wanted to give you a background, a little bit of what we're doing. It's the Rural Heart and Lung Study, a 4,600 person cohort that NHLBI funded. We finally began recruitment in January of 2021, which you can see is solidly in the middle of the pandemic. And the way that we were able to be successful, even in really trying times, really boils down to what's on the next slide. We started by having this core quality standard, and we went through with our external advisors. All of our staff had gone to Disney training, and the Disney Institute, they really emphasize that you have some type of standard that everyone adheres to, that, you know, you put it on the wall, that people think about, and this is what they say when they think about your study. This is what they know that you're taking care of. And for us, it was safety. We wanted the experience first and foremost to be safe. So keeping in mind mobility limitations, modes of transportation, time of day, you know, all the things that might be around the participant safety, making sure that was a key area that we focused on. The second area we really wanted to focus on was courtesy. And courtesy is something I'm going to talk about a little bit more when we talk about staff and staff training, but it's really, really important that all interactions with participants, potential participants, general community members, that they're courteous, they're professional, they're engaging, to start building that rapport when basically you might be talking to strangers. Confidentiality, so that the participants would know that we were always keeping their materials completely safe and confidential, so that no one could find out any of the information in their health record. And then efficiency. We wanted to make sure that we were always efficient with participant time, that there wasn't a lot of downtime, so they were sitting there without anything to do, that we basically had them engaged the whole time, so that the experience would not, you know, become boring at any point in time. On the next slide, we had to adapt to reality. That was one of the things that very quickly became something we had to deal with. We had no idea what kind of participation we would get during a pandemic. You know, no one had done this before, and the study had launched, and the Institute expected us to go forward. So we had to figure out, how are we going to recruit people when we had planned all of these in-person community events, and we wanted to do health fairs and go to schools and churches and libraries and other community events. So we had to pivot and try a telephone-based recruitment. We used a lot of colorful recruitment materials that we mailed to participants in advance, changed up the colors, changed up the logos to try to get them to pay attention to the materials. I really wanted to use the Nielsen way. So what Nielsen does is they put a crisp $1 bill in the envelope when they recruit people, because it gets people's attention. But my institution would not allow me to do that. So it was not something we were able to do. But Nielsen has a lot of luck with just that $1 bill. Again, it's a way to get them to open your materials. That's what you're trying to do. May not respond, but at least they've taken the time to take a look. The other big challenge we had was that when we first got the study visit from all of the different investigators, you know, the heart folks and the lung folks and the sleep folks and the biomarker folks, the length of the visit was about 4 hours long. And we had spent a lot of time in a previous study called Regards. We knew that that was just a really long time to keep people. You're talking about a half day of work, and it's very hard. Although there are studies that have 8-hour exams, you know, 9-10-hour exams. When you're talking about a cohort study where you're actually looking for this person to regularly re-engage with you for the next 5, 10, 15, 20, 30 years, keeping that first visit as short as possible will give them a nice experience that doesn't overwhelm their attention span or their ability to interact in their daily life. So we went through and did the hard part of cutting components of the visit. It's horrible. Every investigator has a pet question or a test that they really want to do, but we basically sat down with everybody and said, okay, tell us the paper you're going to write with this question. If this question is so important, tell us the paper you're going to write as soon as you have the data. And if they couldn't come up with a paper, question was nixed. And again, that's because our focus was on the participant. Lack of participation from young men was the next challenge we had. We had a lot of basically 50-plus-year-old women that were more willing to join the study, but the young men, the 25 to 45-year-old men, we had a really hard time reaching them. So we started to change up the way that we were recruiting. We recruited at a couple of different places once the pandemic restrictions eased. And then we did some word of mouth recruitment. So we, for the people that were enrolled in the study, we offered them $5 for every name of a person that they referred into the study. So we continued their compensation as they put the rural name out there into the community. We also did a lot with to try to create community buzz on the radio, on TV. A lot of the strategies that you saw, what Kathy was showing, the physicians and the staff that were doing presentations for the local media. We tried to do as much of that as we could, and also tried to make sure we described the eligibility really clearly. Because of the fact that not everybody was eligible for the study, it was only people 25 to 65, and they had to live in 2 very specific counties. We wanted to make sure that people understood this was not meant to be exclusive. It's just there were certain criteria that were needed so that we could kind of manage that community buzz a little. When we did this, again, you heard a lot about the participant needs. On the next slide, I talk about some of the things that were really important for us as we thought about our participants. There may be participants that are interested in the research, but the reality is, and this is so hard for researchers to understand, the vast majority of the people are not there for your research. They are there because they either have a personal connection to something or someone about the project. They are interested in the compensation. One of their friends has convinced them to do it, but the actual research for the sake of research is not a high priority for most people. Even if they tell you that, it's kind of like your kid when they tell you, yeah, school was fine today. And it's just that they're trying to make you happy when they tell you, oh yeah, I care very much about your research. It's just, their priorities are just different. They have other things in their life. They have lives that are complex. Some of the things Kathy was talking about, one day maybe they need to ride in with a friend, or they had an appointment and their child got hit in the nose with a baseball and now has to go to the ER. So you have to be willing to work with them and understand that their lives might shift. And if you want them in the study, you've got to try to find ways to shift with them to get them in, which might mean accommodating people in off hours or doing a rapid reschedule, whatever that means, to try to get that person back to you. All participants need to feel welcome. And this is really, really important. We hear a lot when people come in, some bad experiences they've had with the healthcare system, with a doctor, with a nurse, and it's important for our staff to listen, to acknowledge their feelings, and then go ahead and continue with the exam. We want them to know that we hear them, and we hear that they've had experiences in the past, and that we're going to try to make sure those things don't happen again in our clinic. I put this one word in here. Don't say medical words. Just avoid all medical words. We had some investigators. They wanted to ask a question about muscle soreness from statins, and they wanted to ask if the person experienced rhabdomyolysis. We were like, no. Muscle soreness, weakness, tired. Don't use medical words. Participants don't like to have to be kind of talked down to, oh, that means muscle soreness. Just use the common word, the English word right off the bat. Set the stage with your recruitment call. Tell them how long they're going to be there and accurately describe the burden. Don't be afraid to tell them things that might be unpleasant. It's worse if you get them there and they have to experience things they weren't planning for. The compensation needs to match what you're asking of them. That's a really important piece. And you might want to consider scaled compensation, because not all people, 4 hours of someone's time is not the same across the board. I'm a professor. If I take 4 hours out of my day for research, I still get paid the exact same amount of money. Some people actually lose money to be in your study, and you have to kind of think about how that plays into equity. When you can, like Kathy said, go to the participant. Go to where they are to make it easier. On the next slide, I want to talk to you a little bit about staff needs and partnering with your staff. Whether you know it or not, and again, a lot of investigators don't think about this, but the staff are the face of Recover. participants don't know any of the investigators unless an investigator was at a visit. So make sure that your staff are in the right role for what they're doing, whether they're on the telephone, they're in person, they're your social media. Make sure that they are well equipped for that particular role. Help them learn how to take their own ego out of the conversation, either through customer service training or something else that you might have at your university, so that your staff can learn if a participant comes to you with a lot of problems and is having a bad day, it's not their fault. It's not your fault. Just take the ego out of it and help move the conversation forward. You want to make sure that you consider team building for your own staff as well. How do you make sure all of your staff know each other? If you're in a complex organization and you might have a phlebotomist over here and a pulmonary tech over here, how can you do some team building and engagement so everybody on the staff know each other and you can do a really fluid handoff when a participant moves from one staff group to another? And on the last slide, I just wanted to kind of give you an idea of how the results have worked for us. So the Regard study is the first cohort I mentioned. It's a 30,000 person cohort recruited in 2003. We've had a 97.25% annual retention rate because we focus on all of these strategies that Kathy mentioned, that Cheryl mentioned, and that I've been talking to you about. It is a very diverse cohort, all 48 states in the United States. It's 50% Black American, 50% white American, 50% male, 50% female. And we've had great retention results. And then the Rural Heart and Lung Study that I mentioned to you that started up in January of 2021, we have met or exceeded our recruitment targets since 2022, when we finally were able to lift all of the pandemic restrictions and see as many people in our clinic as we wanted to see. So our strategies have really been working for us as we've recruited our cohorts. And I'll stop there so we can have some questions.
Thank you so much, Dr. Judd, and thank you to all of our presenters for your highly informative presentations. Yes, now we'll turn to questions and answers. First, what steps have you taken to reach out to the hard-to-reach participants? How do you keep them engaged? For example, how do you reach tribal populations? I believe this is a question for Ms. Hummel.
Well, I'm glad I talked to my South Dakota site about that just today, or emailed them about that. So in South Dakota, the main site is in Sioux Falls, and they have a satellite clinic in Rapid City, and they're about 350 miles apart. And the Rapid City site does have some reservations near their site. So they are familiar with recruiting this population. That they do come with some challenges. So they acknowledge that their telephone numbers change frequently. A lot of times they have those phones that just have the limited minutes on them. They move often to new housing. They may not have access to transportation or even email. So South Dakota has said that's really important that they keep contact with these participants frequently to ensure that those participants know if you move or you get a new telephone number, please contact us and let us know. A lot of times they'll try to make their phone calls at the beginning of the month while they still have a lot of minutes, so that they're more likely to take the phone calls and be able to talk to the site study team members. They'll even attend events in the American Indian community and try to connect with them in person if they are not able to get in touch with them, like by the telephone or something like that. And then they even used search engines sometimes with IRB approval to try to find and get updated information on people. But they do acknowledge that this is a challenging population to engage. It's hard to keep in contact with them, and it's usually one of their highest amount of lost to follow-up subjects for studies. So, and again, that's a lot. That information, a lot comes from South Dakota. So, thank you guys for that information.
Thank you. So our next question is for any of our presenters. What strategies work best to keep families engaged for several years?
So, again, the key is are those interactions that Kathy was mentioning. It's how they're treated when they're there for that first visit. If you can set the stage in the first visit with a really positive experience with those snacks, with a little bit of swag, with making it fun, then your retention road is so much easier. But then also staying engaged with birthday cards and holiday cards and newsletters and hi from your friends at Recover, just having those regular, at least twice a year touch points where you're reaching out to them so that, you're doing a lot of communicating.
Thank you. Some of you touched, go ahead, Dr. Clark.
I'm so sorry. I was just going to say just one other thing too, is I think it could be helpful to have a broader sense of what we mean by retention as well. And so retention often means what we do to engage the participants who have enrolled in our study. I'm just thinking about a project, longstanding, the Jackson Heart Study, that has engaged families and it has engaged participants now for more than 20 years. And this was about 10 years ago, I should say. I remember traveling to Jackson to do a presentation, as a part of like a junior investigator conference. And I was able to get into a taxi. And the person sort of asked me where I was going. And he knew all about the Jackson Heart Study because of all the work in community building that had been done. And when I got to the event, half the room was, sort of folks from the NIH, other researchers. But the other half of the room were community members who had come in to hear some of the presentations. And so part of, I think, what we should be thinking about when we think about retention is how are we making an impact? How are we providing value? And how are we making our work relevant to communities? It's a sort of, kind of play on that adage, build it and maybe they'll come. But if we all build it together, we're already there. I'm just curious to see how we can incorporate that sort of perspective into the work that we do for retention and recovery.
Thank you so much, Dr. Clark. Some of you touched upon retention strategies for people of color. How can we better address these barriers? This is for any presenter.
So, again, I really think it starts with the key touch points. Make sure that you know your community. We, in the rural study, we have a community engagement coordinator in every community so that we understand the specific needs of that community and that we can hear, like, what's the buzz? What are people saying about us? We also do an exit interview so that we know if we did something wrong in the visit, and we look at those results by a variety of demographic features. But it really, really starts with that positive experience. Make sure that your staff are representative of the community. Make sure they look like the people that are coming in so that the participants feel like they feel they can see themselves there. All of those pieces and parts can help to retain diverse populations.
I think that's right. I just wanted to also have put in the chat. I think we'll learn more in Recover as we do this, but I absolutely feel strongly the foundation for this work has been laid by the community engagement that has happened in our site locally. I want to send deep thanks and appreciation to Jackie Lindsay, who is on the engagement and committee and who is really leading our efforts locally, and to Jacqueline Rodriguez Lewis, who is leading our community forum, and all of the folks. I see Hope White is here. I mean, just there are so many investigators who embody this this commitment to equity. And I think all the discrete strategies that have been talked about are important parts of that, but making the commitment, I think, to the values is something that I think that will put us in good stead.
Okay. Next, thank you, Doctor. Next question. Any strategies to delineate between badgering versus retention activities?
Definitely, we try to only hit a couple of times a year. We don't want to, I would say quarterly would be the absolute most often you want to contact folks. You also want to be careful when you're scheduling visits, take their no. Ours is 15 phone calls. If they don't return our call after 15 phone calls, we stop. Don't keep trying to call them. That comes from the survey research literature. And we take that as a no. Okay, you don't want to see us this time. Maybe you'll talk to us in 6 months. So just being very careful and cognizant of how you're communicating.
And I think we just I think the new protocol that just came out specifies, like, for a study visit, that we'll contact a patient 5 times via 2 or 3 different modalities. So like a text and an email, or email and snail mail, or whatever, for a participant for a study visit, for up to like 4 visits. So if they miss their 6-month visit, then you try again at 12 months, and you do that 5 attempts via 2 or 3 different modalities until I think like month 24 or 36, and then we consider them lost to follow up. So shout out to the, Recover. They really are, we really are working, the coordinators are working behind the scenes to retain these participants. But like I said earlier, I think it'd be fascinating to kind of get family perspectives on what they think is too much, and when we're badgering them or bothering them.
Excellent. And that leads into our last question. What do you recommend for the timeline between contacting for a visit? Every other day or every 3 days, and so on?
That's going to depend on the study visit itself. So in the very beginning, like of Recover, we have some participants who have to complete surveys at enrollment, week 2, week 4, and week 8. So those contacts are going to be much closer together. And then, so it may be once a week or once every 2 or 3 days. But when we get out into the study, when we're seeing the participants like yearly, I will probably suggest to our study coordinators and our study team to start that initial contact at the beginning of that study window. So if they're due in June, we can start, April, May, June. So maybe start in April, trying to get them to get scheduled. So that way you have time to work up to the target date, is just kind of what I'm thinking in my head.
Thank you so much. So we thank again Ms. Kathy Hummel, Dr. Cheryl Clark, Dr. Suzanne Judd for your very informative presentations. And we do say that we can provide you the recordings and information will be sent to you via email. And they are also posted on Teams to answer that question. So let's go to the slide on staying in touch. To stay in touch, you can go to recovercovid.org. You can email us. And we please want you to complete the survey link in the chat, if we can post that again, to give us feedback on our presentation today. So recovercovid.org, recover, and then email us at recover_CSC@nyulangon.org. And please complete the follow-up survey. Thank you again to all of our presenters. There was one additional question about working with community-based organizations. We weren't quite ready to get to that, but we will see if we can email you that answer. But please, before we go, please take a moment to answer our survey and feedback about this Learning Hub. And this concludes today's meeting. Thank you again to everyone. Again, super informative, especially as a study participant myself. Very, very informative. Thank you all so much. Have a good rest of the day.